Well, welcome everyone. We are so glad to have you with us today. We are here for ADAA's webinar, When a Loved One Won't Seek Mental Health Treatment, How to Promote Recovery and Reclaim Your Family's Well-Being. My name is Jolie Busby, and I'm the Education and Training Manager here at ADAA. So a little housekeeping for today's session. This webinar is being recorded. Closed captioning and translation are available. Attendees at today's session will receive a link to the recording within about 48 hours. So this webinar is question and answer enabled, and we ask participants to use the Q&A feature to ask their questions today so that we can try to get to everyone. And with that, I am pleased to introduce our presenters. Dr. Melanie VanDyke is a licensed psychologist at the U.S. Department of Veterans Affairs and the Center for OCD and Anxiety-Related Disorders at St. Louis Behavioral Medicine Institute. She specializes in treating anxiety-related disorders such as social anxiety, panic, hoarding, and OCD. Dr. VanDyke has authored numerous research articles, book chapters, and educational materials for professionals, patients, and families. Dr. Alec Pollard is founding director of the Center for OCD and Anxiety-Related Disorders at St. Louis Behavioral Medicine Institute and Professor Emeritus of Family and Community Medicine at St. Louis University School of Medicine. He's a licensed psychologist who works with a range of obsessive-compulsive and anxiety-related disorders with a special interest in obstacles that inhibit the pursuit of recovery or interfere with effective participation in treatment. Welcome, Dr. VanDyke and Dr. Pollard. At this time, I'm going to turn the presentation over to you, Dr. Pollard.
All right. Thank you so much. It's a delight to be here. So the way we've divided this up is I'm going to do the talk, and Dr. VanDyke is going to be answering questions during the presentation, and we'll try to get done by 1/4 so that we have 15 minutes for Q&A. We'll try. In the meantime, she'll answer questions during the talk, and any questions that she doesn't answer are probably going to be ones she's flagged for the whole group to hear. So that's how we're going to do that. I'm going to go ahead and share screen here. There we go. I want to acknowledge our other team members, Gary Mitchell, Heidi Pollard, and Gloria Mathis, that co-authored the book upon which this talk is based. So let's start with an anecdote. Ms. McGillicuddy, her family wants Dr. Typical to treat their son, but her son doesn't think he has a problem. And he has absolutely no interest in getting professional help. So let's see how that goes here. I'm sorry, Ms. McGillicuddy, there's nothing I can do. Your son doesn't want help. Tell him to give me a call when he's willing to work on his OCD. Now, this is an actual therapist. I just want you to know this is a reenactment. Now let's see how Ms. McGillicuddy liked that. Well, thanks a lot for nothing, Dr. Typical, you lousy. And then she says some things I can't repeat. I guess we'll just keep suffering. Sorry I bothered you, Your Highness. Well, that's not good. The family is left to struggle with the problem. And sadly, that's a very typical scenario. Families all over the country and all over the world are grappling with someone in their family that has a mental illness who will not get help or otherwise pursue recovery. And the consequences of that are big time. One family member with a untreated mental illness can have huge negative effects on the rest of the family. It can compromise their physical and medical well-being, their psychological, their social and financial well-being. Now, if you add to that one extra burden for families who are dealing with what we call a recovery avoider, and we'll talk more about what that means. In other words, a person who is not really fully pursuing recovery, that adds another burden here for the families because it's really hard not to feel resentment or guilt, like what maybe I'm not doing something right, resentment about um, how the rest of the family is affected by this person's apparent unwillingness to seek help, and certainly hopelessness. Because if the family stress related to the mental illness rests on this person to go get help and they're not doing it, you can understand how people would feel hopeless. But today we're going to try to give you a more optimistic note. But first we have to understand some terms. And what is recovery avoidance? Well, here's our definition: persistent failure to pursue, explore, or take advantage of resources and opportunities available for resolving problems or improving health or functioning. Now, a few things to keep in mind about recovery avoidance. And this may be the most important one. When we call somebody a recovery avoider, we're referring to the outcome of their behavior, the effect of the behavior on their life. We're not talking about their intention. In no way do we believe that people are intentionally staying disabled. Now, they behave in a way that's consistent with disability, but that's for other reasons that we're going to talk about, but it certainly isn't their intention. Also, recovery avoidance is a pattern of behavior. It's not just like one-time event. It's an ongoing pattern, and that has significance about what you can do about a pattern of behavior versus a sporadic one-time event. And we also want to make the point that recovery avoidance is actually really in everybody. Everybody does one time or another some kind of recovery avoidance. How many of you have had trouble staying on a diet or following your doctor's orders on one or more things, kicking a bad habit? And I'm guessing there's more than a few of you out there who don't um, take proper teeth, excuse me, don't take proper care of your teeth. Do you floss twice a day? Come on, tell the truth. So the point here is this, that recovery avoidance, in other words, acting in ways that are incompatible with your own health or functioning, is a pretty common phenomena, and it happens all over the place. The problem is when you have a mental illness and you're engaging in recovery avoidance, the consequences are pretty significant. So how does recovery avoidance manifest itself? Well, you have some folks who they don't have a problem in their minds. The rest of the family thinks they do. Their friends think they do, but they don't think it's a problem. You have others who acknowledge the problem, but deny that it's psychiatric. It's a quirk, it's this or that. Or they agree it's psychiatric, but they downplay the severity. It's not that bad. I can handle it. Or they acknowledge the severity of the problem, but they won't seek treatment for a number of different reasons. Or they seek treatment, but the wrong kind. They're looking out for the latest fad or supplement that they can take that will cure them. Or they're searching for an explanation for their condition when a number of people have told them that it's psychiatric. Or they may seek the right treatments, but never really seem to benefit from it. All of these are examples of different forms, different expressions of recovery avoidance. And as I said, it's common. I'll let you just read over these without going over it. Here are a few examples in different areas. And one of the points I want to make is that recovery avoidance isn't just about mental illness. You can avoid recovery from physical conditions by not doing the things your doctor says. Physical therapists will tell you that often they have a lot of trouble getting their patients to do their therapy homework. practice the exercises they've been given. All right. So what causes recovery avoidance? Why would anybody engage in behavior that seems incompatible with their own best interest? Well, let's start with what doesn't cause it. Recovery avoidance isn't a function of laziness, or lack of willpower, or willfulness, or desire to be disabled. Nobody wants to be disabled. Now, it may be tempting to come to those conclusions because if you have no other way of understanding your family member's behavior, these are things that people usually fall back on to try to make sense of it. Well, clearly he's lazy or he doesn't want to get better. And those things couldn't be further from the truth. Now, you have to be careful, as tempting as it is to fall back on these explanations, there are some reasons not to. They're not really explanations for behavior. They're labels, first of all, and they're pejorative labels. And they actually don't offer us any clues for what to do about recovery avoidance because they're simply labels, not mechanisms that actually might cause recovery avoidance. And finally, when you dig into some understanding that my loved one is willful, my loved one is oppositional, whatever, it creates the emotional justification for treating that person in a way that not only is not helpful, but actually makes things worse. And we'll talk about that more. So where do we turn to really understand recovery avoidance? The science of human behavior. Now, it's not our job, and it's not your job to fix the loved one in your family. We just want you to understand some of the reasons why the person in your family might be behaving the way he or she does. And there are four major factors that we've identified that drive recovery avoidance: treatment interfering beliefs, skill deficits, motivation deficits, and incentive deficits. We'll just touch on each one quickly. Treatment interfering beliefs. Let's say, for example, that your family member believes that treatment won't work, or that they don't have a problem. Well, if you don't believe you have a problem, why in the world would you seek help or even seek recovery in any other way? Because you don't have a problem. And these are not unusual beliefs that some people hold, that they really have become emotionally connected to, and that these beliefs are held deeply by them. And that's one of the reasons why someone might act in a recovery avoidant way. Second one is skills deficits. We sometimes underestimate how many skills, basic skills of life, are needed to function well, to do things. And let's say the simple act of making an appointment with a provider involves a lot more skill than we might think. You have to have the ability to find research and find a provider. You have to then choose one. You have to then make a phone call or take the initiative to set up an appointment. All of those things take organizational skills and time management skills in order to do that. And not everybody has them. Motivation deficits are when you don't have the kinds of long-range aspirations and goals that you need to really care about recovery. You want to go to college, you want to get married, whatever. If you don't have those, and/or you don't perceive that your disability is going to impair your ability to get those, then you would have what we call a motivational deficit. And finally, incentive deficits. So motivation is that desire to achieve these long-range, bigger goals. Incentive deficits are the things that impact your life uh, in the here and now. So, for example, rewards and punishments around life, the incentives that really affect, like you get up in the morning and you want to stay in bed, but if you don't go to work, you're going to get in trouble with your boss. That's an incentive. That drives behavior. So some people may have um, uh, disincentives that compete with the incentive to pursue recovery. Now, as I said, um, those are the reasons. Now we're going to take a test here to see if what you've learned. According to the science of human behavior, which option below best explains recovery avoidance? A, laziness. B, desire to be disabled. C, communism. D, treatment interfering beliefs, skill deficits, motivation deficits, and/or incentive deficits. Well, I hope you picked D, because if you didn't, I did a really lousy job just now giving this presentation. All right, now you've got somebody who has a recovery avoidance pattern. That, of course, affects the family often, because mental illness is indeed a family affair. So how do families respond to recovery avoidance? By the way, it makes a big difference. So there are two kinds of natural things that we do if we have somebody who's struggling. Number one, we want to help. That's a good thing. And number two, we want to persuade them to do as well as they can, to work on whatever it is, the challenge that they have in front of them, excuse me. So of course, they want to help the RA function better, RA simply meaning recovery avoider. They want to persuade the recovery avoider to do better, to seek treatment, whatever is necessary to try to get better. And why wouldn't you? I mean, helping is a good thing, right? People volunteer to help others. Persuading someone to do things better is a good thing. That's what coaches are about, for example. So one person needs help. Another is willing to provide it. What could possibly go wrong? The answer is plenty. So let's talk about how things go wrong in the family. And I hope you've gotten the message so far that it's not that any single family is doing something wrong, as if they should have known what else to do. There's no reason to expect families to know how to deal with this situation. There were no courses in high school about this. So we understand that the natural response of families is exactly what any of us would probably do to begin with. But a response that is actually helpful in one situation can be not helpful in another. I'm going to use the loan analogy from one friend to another to explain this. So let's say you have a friend of yours who in their last semester of college, and they need a little money to get through so they can graduate and get a job. So you loan them $1,000 or $500, whatever, to help them get through. Now, if that person's not a recovery avoider or doesn't have some other problem, that works out really well, because then they get a job and they put themselves on a payment plan. You guys agree on it, and they send you reliably, pay you back month after month after month until it's paid off. And that's the way it's supposed to work, and sometimes can work. In that case, that giving that loan to your friend was a win-win for you. Feel better. You've helped a friend and they got through college. But what if the person you're giving a loan to has issues that are going to interfere with their ability to function well in the process of paying that loan back? So you give them the money months after they graduated. They may or may not still have a job, but you haven't gotten any payments. Or if you got something, it's a partial payment. It's not really what they said. Or if you got the full payment, it's not really on the schedule they said they were. Bottom line is they're behind in paying you. And so you call them, give them a little nudge. Hey, and you're nice about it at first. But then when they don't respond well, you get a little crankier and then they get a little more defensive, and then things deteriorate where you're kind of bugging them and getting angrier, and they're avoiding you because you're a pain in the what, and it doesn't work out well. So the same behavior, giving a friend a loan in one situation is a very, very positive thing, and another not so good. So we have to understand that the same behavior, sometimes we don't know how it's going to turn out till we actually try it. Now let's see how these guys, how theirs turned out. Oh, Lord, no, that one didn't go so well. All right, well, see, they didn't know. All right, so when you're dealing with a recovery avoider, unlike someone who's not a recovery avoider, helping devolves into what we call accommodating, and persuading devolves into what we call minimizing. And once you're into accommodating and minimizing, we've got problems. So let's find out what these things mean. Now, probably more of you understand, by the way, we just use OCD as an example here, but it's really about any condition. It could be depression, it could be social anxiety, whatever. Um, so accommodating is trying to help somebody out, to do things for them, to help them function better, or to, keep peace in the family if there's conflict about it. But the problem with accommodation is there's an implicit message that you cannot do this on your own. I must do this. And that's a message that is not a good one in the long run. So there's two kinds of accommodations. There's accommodations of commission. These are the things you take on, the things you do that you wouldn't ordinarily do for someone of the age and ability otherwise of the loved one that you have that's a recovery avoider. These are the things you do in response to that person's limitations or demands to try to compensate for them, whether it's doing their laundry or trying to get them up in the morning, convincing them to go get treatment, whatever it is, these are all accommodations. There's another form of accommodation that we think is not recognized as often. Those are accommodations of omission. These are the things you give up, the life activities, the valued activities of your life that maybe you've cut back on or neglected because of the time you're spending with your loved one trying to accommodate them. So let's go to the second family response. There's accommodating, and the other one is called minimizing. This is any behavior, verbal or otherwise, that's sort of persistent behavior between you and the recovery avoider, and I should say ineffectual behavior that's intended to influence an impaired individual to change. Now, the implicit message of minimizing is you can change because of something I say or do. You'll be able to snap out of it if I just tell you the right thing for the 400th time. And that's often the level we're talking about. So minimizing, we call it minimizing because the message is that you don't get it, that you don't, a message that goes to the recovery avoider is that you're trivializing the things that are driving their behavior as if they could just snap out of it, and they can't. So we call it minimizing. Now, I'm going to show you a list of common minimizing behaviors. So this is just a warning that the behavior list you're about to see is not pretty, even though some of them may be familiar. lecturing, nagging, pleading, threatening, name-calling, criticizing, venting, shaming, guilting, expressing frustration, arguing. These are just a few examples of minimizing. Now, I want you to just, those of you who recognize some of those behaviors in yourself, I want to ask you, it's time for self-compassion. Take a deep breath. You're not a bad person. This is the way it goes. Repeat after me. Neither mental illness or recovery avoidance is my fault. I did the best I could given what I knew at the time. And doggone it, people like me. That's optional. You don't have to put that one in there. Okay, here's the point though. If you stand in a tornado, your hair will get messed up, which is a terrible analogy for me to use because my hair would not get messed up in a tornado, but it's such a good analogy. I still use it. And what we mean by that is that once you're in an impossible situation, your behavior will not be pretty. And there's no way around it. So looking back and judging yourself or shaming yourself for behaving in not so pretty ways is really a waste of time. You need the same compassion that we want you to give the recovery avoider in your family. Everyone deserves compassion. That doesn't mean that you have to be a victim of recovery avoidance. It simply means understanding what drives people to do things and trying not to judge, just trying hard to change is the right thing. So if you haven't guessed it by now, you probably know that minimizing and accommodating are not good things. Minimizing is bad for the recovery avoider because it generates negative emotions, defensiveness, distrust, and those things increase recovery avoidance. It's bad for family members because it increases conflict and distress within the family. It comes back to haunt you. It's not a one-way thing. And so if you haven't gotten this message now, the very things that I'm calling natural things to do are actually make things worse and contribute to recovery avoidance. What about accommodating? Yeah, it's not so good either. For the recovery avoider, it actually reduces incentive because when you do things for the person, you're taking away opportunities for them to practice recovery behavior, and you're also shielding them from the negative feelings of the consequences of not going to get help. If you shield them from the negative consequences of their disability, you're taking away the normal motivation that all of us use to go get help. We go to the doctor when we feel bad, when we feel some kind of negative feeling, or when we're frustrated because there's something we want to be able to do we can't do. If we don't have those things, then we don't have the motivation to go get help. And really, truly, it's bad for you as family members. Because with each accommodation you make, you add a burden to your life. And those burdens add up and make you more likely to engage in minimizing. So we'll do a little math. Recovery avoidance plus accommodation plus minimizing equals what we call the family trap. So here's the trap. We start with, we'll go in order of the numbered boxes. Box number 1 is recovery avoidance. As you can see, that leads the family to accommodate. Number 2, then box number 3, that reduces the incentive to seek recovery for the RA, which means it reinforces recovery avoidance. So our first cycle is box 1, 2, and 3 of perpetuation of the family trap. Now, if we go up to box number 2 and we take it over to box number 4, we see that the family is burdened when they make accommodations, and that affects their well-being. That means in box 5, we see that the family is minimizing, which in box 6, we see makes the recovery avoider more anxious, angry, and defensive, and distrustful, which reinforces more recovery avoidance, and the cycle continues. So let's use Sid's family as an example. Sid won't get help. He has severe OCD. He demands elaborate rituals when his family re-enters the home from being outside. They have to remove their clothing in the garage and put on a bathrobe, go into the shower, and redress each time they come in from the outside world. As what that does is reinforce Sid's OCD and his recovery avoidance, because Sid is freed of the discomfort that would come if they came into the house and didn't follow his ritual demands. And therefore, some of the motivation is there. And he also doesn't learn how to cope with those feelings. At the same time, the family becomes increasingly resentful because of all the extra things they have to do because of Sid's demands. That leads them maybe to not always be so nice. They lecture, they nag. His sister calls Sid names, which of course does not help. Sid is convinced that nobody gets it, nobody understands, gets more defensive, more anxious, because he's now in a household with people that don't understand and don't get it and are expecting me to change. That raises his anxiety, and guess what? That raises his avoidance and recovery avoidance. That is what we call the family trap. Everybody is locked in to a pattern of behavior that they don't seem to be able to get themselves out of. So now you'll be excited to know we're not going to leave you there. We're going to talk about the way out. Okay, now remind yourself of this family trap diagram. All right, here, this is where it is. In our approach, which we call the family well-being approach, we have a different approach. We'll start with the serenity prayer, because it's very important to remind yourself of that. Grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. And almost all of you have seen this prayer. There really is some very useful ideas in this simple little prayer. It's sort of the philosophical foundation of the approach we take to help families. So now here's that pesky family trap diagram again, but you'll notice that box 2 and 5 are X'd out. Now, why is that? Because that is the focus of our approach, to help families reduce the accommodations they make and to help them reduce their minimizing. Why? Because those are the two things that they have some control over. They don't have control over the recovery avoider. They don't have control over how upset they'll get if they keep accommodating, because that is not something you can just will away. If you accommodate, you will get stressed. So we would tell you that families are more successful in dealing with recovery avoidance when they accept what they cannot control, understand what they're doing, that it's not working, and probably making things worse. They stop trying to change the recovery avoider by accommodating and minimizing them, and instead start developing realistic goals, and they focus on changing their behavior. And here's something very important. The reason that we call this the family well-being approach is because our priority is on the well-being of the entire family, not just the person with the mental illness. Everyone deserves psychological well-being. And that is not what's happening often in the families we work with, because they're focused directly on trying to change the recovery avoider. and sometimes ignoring their own well-being. We focus on improving their well-being before attempting to promote recovery behavior in the RA. Now, let me stop right there. Many times people come to us and say, what can we say that will change the recovery avoider? They may not ask that way, but that's kind of what they mean. And we say, we're not even going to talk about that. We're going to start with your well-being. What can you do to help your well-being before we even talk about targeting the person with recovery avoidance? So, and then once we've done that, then we can turn to how you might be a positive influence on the recovery avoider and move them in the direction towards recovery. But that will be by promoting, by influencing them, not by commanding them. And hopefully you will be using proven behavioral principles to influence the RA rather than things like nagging and prodding and threats and etc. So our family well-being approach has 5 basic steps. Prepare for crisis, redefine the problem, embrace valued activity, ease family distress, and create a family-friendly environment. So let's go to step 1. In step 1, we get you ready for crises. Because if you start making changes, often the recovery avoider may respond sometimes in ways that are fine, but sometimes not. Sometimes they may get dramatic. They may talk about suicide. They may get physically aggressive. And one of the main reasons that families don't follow through with the changes they try to make is this, that they get intimidated by the behavior because they're not prepared for it. And then they fall back into the family trap, accommodating and minimizing. So we want you to have a good, solid plan that you've really thought out and strategized before you do anything else. Once that's in place, then we sit and redefine the problem. We ask you to really take a look, instead of looking at how you're going to change the RA, how has the RA's behavior, how has the recovery avoidance and the mental illness affected your life? And there are usually 3 negative impacts: the loss of valued activity from accommodations of omission, the burdens that come with accommodations of commission, and the increased family distress and conflict that comes from minimizing behavior. So we're going to take a look at all those effects and how they've affected your life, and then ask you to prioritize where to begin, what changes are most important to you based on your situation. The next 3 steps, or at least the next 2 steps, are attempts to follow up on that redefinition of the problem. So step 3 is embracing valued activity. That is, taking a long, hard look at things you might have let go of in your life. And why is that so important to get those back? Because they replenish your well-being. And our whole principle here is, when your well-being's not good, you don't deal well with the recovery avoider. There's a reason why the flight attendants tell you to put on your oxygen mask before you put the one on to the person in your family who might need it, like a child or someone who's disabled. Step 4 is where we start reducing, accommodating, and minimizing directly. We ease the family distress. We put a plan together and prioritize which counterproductive behaviors among accommodating and minimizing we're going to start with first, and systematically start pulling them back a week at a time, or whatever pace you feel is necessary, to really start changing your life. Now, I should say that communication is really important. So at each of these steps, we're going to encourage you to let the person in your family, the recovery avoider, know exactly why you're doing it, what you're doing, and when you're going to start doing it. Not just to start doing it. but to give them notice. Once you have reduced accommodations, and by the way, we're talking what is ordinarily months and months and months. This is not a 3-week process. But once you have really pulled back on the accommodations and minimizing, such that the tone in the family is better. And that's what usually will happen. If you're consistent, eventually there's less conflict in the family because the rest of you have stopped trying to get the recovery avoider to do something. And that's what creates a lot of the conflict. Now, yes, you say, what? You're going to let him sleep till noon? For now? Yeah. We're going to let him sleep till 3 in the afternoon until you've got your family, the rest of the family, back in terms of their well-being where you think they need to be. Later, we'll come back to step 5, and that is to create a recovery-friendly environment. That means that you're going to look at ways, not by nagging and prodding, but how can you positively influence change in your loved one towards recovery in ways that don't create the power struggles. And that's what step 5 is about. Those are the 5 main steps. Now, there are some steps that some families will need to consider. I'll start with number 2, which is professional consultation. Many of you, if your family's in this situation, some of you will be able to do this just by following the steps in the book. However, some of you will need consultation here and there, if not consistently, from a professional, and that's fine. There's nothing, everybody's family situation is not equal. So that's one thing that some families consider, is getting a professional involved in, not in trying to change the RA, but in helping them deal with the RA. Number 3 is planning for the road ahead. So regardless of how much better your loved one gets, you may need to look down the road and plan for long-term issues. Will this person in your family be able to function independently? If so, great. If not, you may need to make some plans for how, in the long run, you're going to handle that. And now back to 1, which is removing a foundational accommodation. A foundational accommodation are the things that the person needs for life: food, shelter, healthcare. These are foundational accommodations, and many families are providing foundational accommodations. All the other accommodations are what we call situational accommodations. They're things you do for them in a particular situation. Now, removing foundational accommodations, we generally are advising people not to unless you have to. And there are some conditions under which you might have to, but we encourage people not to unless they really have to. Because first of all, it puts the recovery avoider at risk usually because they're not prepared to live on their own. Secondly, generally families aren't good at following through on it. They start feeling guilty, and then they don't follow through. And then when they don't follow through, they lose just a little bit more credibility with the recovery avoider, because every time you say you're going to do something to the recovery avoider and you don't do it, you've lost more credibility, which means each thing you do next becomes harder, becomes challenged more. The recovery avoider doesn't believe you'll follow through. So we emphasize a lot, take smaller steps, don't get too ambitious, take smaller steps, but follow through. Okay, but you might be saying, does this really help? Well, remember our family that called Dr. Typical? This is them before they did family well-being approach to life. And look at them now. What better proof could you ask for? Extremely, extremely happy family. And hopefully they read our book. And So forgive the blatant plug, but everything we said today is based on this book that just came out May 1st, called When a Loved One Won't Seek Mental Health Treatment. If you do buy it, we hope you'll find it useful. Okay, that's the end of my talk, and I will open it up to questions.
And Alec, I wanted just to repeat one of the questions that was asked, and just make sure that we've covered that. One of the questions was, my efforts to enforce reasonable expectations with my wife usually result in a power struggle or collapse. How can I avoid that? And very early in the talk, I said, well, stay tuned. We're going to come back to this. And I started the answer, but I thought this one might be really helpful for a lot of folks. And so I thought we could really begin with this one. The kind of the first part of it is focusing on what we control, is typically going to be most helpful in trying to avoid power struggles. Second, kind of doing kind of just as you've described, kind of doing one thing at a time, doing kind of a small thing consistently is going to be most helpful. And kind of probably the most straightforward is, if you want to avoid power struggles, don't make demands. Just talk about what I'm going to do for myself.
Yeah, I would agree with that. And again, I know that may sound naive to some of you out there, like, well, how can we not make demands? There are ways to do it. I want to start with an analogy of two people tugging on the end of a rope, on each on one side of the rope. That would be our power struggle analogy. It doesn't happen unless both people are pulling on their side of the rope. If one lets go, there's no power struggle. Now, I know that real life is not quite that simple, and the reason that I know that is because I live in real life, and so I've learned from my own experiences. But I'll just give you a concrete example. If my spouse is engaged in either they're too tired, or they're fatigued and take forever to get ready to go out, or they're engaged in some kind of compulsive behavior or whatever, for whatever reason, when we're ready to go out, my spouse is not ready. And I've told her multiple times over the course of the day, we're leaving at 5, we're leaving at 5. And yeah, she's getting increasingly irritated with me because I keep reminding her. That's all minimizing behavior. And then 5 comes along, she's not ready. So I go in and I nag her, I pester her, she yells back, I try to get her to hurry up, I hover. That's a power struggle. Okay. But if I focus on my own behavior and I say, look, I don't want to fight with you about this. I really don't. But I also don't want to be mad at you because I'm waiting on you. So if you can't be ready, I get it. I understand it. I promise I'm not going to get on your case, but I'm going to have to leave on my own and go ahead and have dinner. And otherwise, I'm going to be resentful and mad, and I might treat you poorly. So just so you know, I'll give you one warning, 10 of before I leave, but then if it's 5 and you're not ready, it's okay. I'm going to go ahead and get something to eat for myself. That's an example of, and so yes, you limit those demands to things that are really urgent, that are really like crises and things like that. But things that really don't have a significant outcome, you try to stay out of those arguments, and focus on what you can control.
Yes. So I think that's a nice segue to, I've got a couple of questions specifically about foundational accommodations. For instance, what happens if their behavior affects their health and they need my assistance, but they don't follow through? What can I do? And can you give more examples of foundational accommodations rather than situational?
Well, there's basically big 3 off the top of my head. It's shelter, healthcare, and food.
Mhm.
That really are essential to life or basic safety, we would say. Now the now the question about now I've forgotten what it was exactly, Melanie. The question was about
If their behavior affects their health, but they're
oh
not following through.
yeah
And so it kind of it strikes me as being kind of more one of those foundational accommodations, and one that's much harder to not give the accommodation for.
yes. So most of the time, let's just start with this idea. You can there are some limited things that you may have to just say, I don't care, this is what I'm going to do. And the cost of my loved one not taking their medicine, which might be life-saving, is too great for me to not micromanage it. Okay, if you're going to do micromanaging, where, if you don't, I'm going to check with you every day at 10 o'clock. If you haven't taken your medicine, I'm going to bring it to you, or whatever it is. That's an accommodation. But if that's one of the few accommodations you're making because you prioritize just the ones that are life-saving, then it's probably not going to be too problematic. But if that's one of a dozen other minimizing and accommodations that you've made across the day, hey, you got to get out of bed, you got to do this, you got to do that, it all adds up. So if you're going to do those things, and we encourage people that sometimes you do have to try to do something to manage the other person, but you really need to limit it to those fundamental things. So you have, and it also creates credibility in the mind of the recovery workers. Okay, they're not bugging me about everything. I can see the difference between not taking my medicine versus I didn't get up on time. So yes, there are some situations, but they should be pretty limited. And most families are doing way too much of it. They're not discriminating.
Excellent. There are lots of questions about, like, how do I find a therapist? How do I find someone who I can talk to about this? And kind of an easy resource is ADAA, that they have the Find a Therapist, and so you'll get somebody who specifically has a specialization in either anxiety or depression. And I know I also said that we are working really hard to train therapists so that we have more folks that are familiar with our approach.
We are, and there is an online resource to those who buy the book that we're going to have a list of therapists online that are trained, and we're going to be updating it, thankfully, because our goal is in the next 6 months to get lots more people trained in how to help families in this situation. So we won't argue that there's not a lot of people out there. Most of them are doctor typicals out there. However, if you do call, there are people who will help. If you do call people, a couple of tips is make sure they understand that you're calling to get help for yourself right now and get your well-being better prepared to deal effectively with the recovery avoiders. So make sure they understand that. You might use words like codependence. If they don't know what a recovery avoider is, they might know the word codependent, or I need some help with my codependency. And there are people that are capable of doing that. And if you have our book, and even better, that they're willing to kind of go through the steps of the book with you, that even better.
And Jolie added in the chat the link to ADAA's Find a Therapist as well. So kind of to give folks a place to start. Great. We have a one question about what can we do to protect a small inheritance for the loved one. And so I think that would fall into that last chapter, which is really looking at kind of planning for the road ahead.
Yes, and we also provide links to resources either in the chapter or on the website
online.
online to different, depending on the issue for long-range planning, like who you might contact. If not specific names, just like categories of professionals that might be able to consult with you on different issues like finances or housing or things like that.
Absolutely. I had a very similar question. I have a therapist who asked, how do I get trained? And so, so we are working on that piece.
Well, I can tell them if you have a therapist, I'm meaning any families out there who might be willing to get interested and get the training, they can contact Sue Mertens, our administrative assistant. She's keeping a list of therapists' names for our training, which will probably be in August, the first one. And so they can contact her at 314-534-0200 extension 407.
Could you say that one more time?
Yeah, 314-534-0200 extension 407. And she will put the therapist name on a list for the training. It looks like we got a few more minutes. Do we have any other questions?
We have another request for foundational accommodations. I think those are just tough to, yeah, that again, we're talking about housing, we're talking about basic healthcare, we're talking about kind of basic nutrition.
Yeah, let me just say too that a lot of people have heard of tough love, for example. That's a term that's out there, and a lot of people will say you got to have tough love, you got to just kick them out. There are situations where that might be indicated. You just have to be very careful about it because people in general aren't inclined to have kick their kids out, or yeah, generally it's kids. Sometimes it could be another family member, and have them kind of fend for themselves if they feel they're not capable of doing it. So again, the danger is in a moment of frustration or anger, and that's the problem. We try to get people away from impulsive, emotional decisions and step back, delay, strategize, think about the consequences, and be prepared for the consequences so you'll follow through. And but in a fit of anger, I say, yeah, out of my house, get out of here. And then later you get guilty, and then they call, they're from the homeless shelter. I got to go pick them up. It's just, if you can do it and it's appropriate. By the way, one of the exceptions is when the presence of that person in the house poses a threat, physical threat, or even a serious psychological threat to the rest of the family. That's different. You may have to kick them out, or if the financials of supporting someone becomes a financial threat to the well-being of the family, you may have to stop supporting them because of the family's financial welfare. So when there's serious threat to the welfare of the family, those are the times you might consider it. But again, even then, you need to be prepared.
All right. I think we are just about out of time. I was going to share one comment that came in, which is, I think I'm getting it, but I don't like it. And as soon as I heard that, I thought, oh, you get it. You're getting it.
That tells us you do get it. There's nothing to like about this, by the way, except the only thing you ought to not like more is not getting it.
Well, I will take that as our wrap up for this wonderful presentation. I just want to say thank you so very much to Dr. Pollard and Dr. VanDyke for presenting this incredibly informative and helpful presentation clearly resonated with our large group of attendees today. I'm sorry we weren't able to answer all of the questions, but I will share an email address at the very end. If you want to reach out to us, I will connect you as best I can. And so with that, just a little bit about ADAA. So the Anxiety and Depression Association of America works to prevent, treat, and cure anxiety disorders and depression through the alignment of science, treatment, and education. We invite you to explore our website at adaa.org, where you can find resources such as the Find Your Therapist directory, free evidence-based webinars, blogs, and videos, our free online peer-to-peer communities, self-help books and publications. And we also ask that you please consider subscribing to our free monthly e-newsletter, Triumph. And again, thank you so much on behalf of ADAA and our presenters. We appreciate you joining us, and we'll see you next time.
Thank you.
Thank you.